All right, we have a wonderful case here to take a look at, and where I would like to begin is a good review of some basic surgical guide lessons here. So when I look at this case, the first thing that I notice is that we have radiographic markers in here, and that would be these right here. This immediately tells me that our intention is to use a CCAT classic guide. So my first question is going to be, what are the three types of guides we can do? Number one is a classic guide, number two is the opti guide, and number three is the CEREC guide. Obviously this case is not a very good case for CEREC guide, so we're going to go ahead and throw that out the window. And then really the big question, and 95% of the time the question is this need a classic guide or can we do opti guide? And this case is done correctly. This is a case where we really need to do a classic guide. So again, the big question is, why do we need to do a classic guide? And the answer is we can always do a classic guide, but the bigger question is, why can't we do an opti guide? And the answer for this is quite simple. To do an opti guide, we need to be able to register our CEREC data into the scan. To be able to register the CEREC data into the scan, we need two natural teeth to be able to integrate. Now the issue that we have here on this particular one is that these restorations right here, these teeth right here all have restorations on them. We can see that they have some, looks like what looks to be porcelain type restorations on there. When we have porcelain restorations on teeth, it produces scatter, it produces different issues, it doesn't show up as well radiographically as, for example, these natural teeth down here, and then it becomes much more unpredictable and more difficult to be able to merge the data sets together. So this case is properly done using an opti guide. Now, when we look at opti guide, we need to look at a couple of things. Are we going to do a simple opti guide? In other words, replacing one or two teeth, place some bite registration in the in the bite plate, and place it over the teeth. Or are we going to do what has been done here, where we have a radiographic surgical stent made with the teeth and barium sulfate, with the surgical bite plate bonded to the surgical template, and then scan in the mouth. So when we have distal extensions, certainly two distal extensions like this, it makes all the sense in the world to go ahead and have this scanned as it is. So great job on choosing the right surgical guide. I hope it wasn't by accident, by good planning and knowledge. So now let's go ahead and focus on the case. So we're going to take a look at this particular plan. So our plan here, as it looks like, is to replace the upper right hand side. We're missing tooth number 5, 4, and 3. Typically when we replace teeth, we're not replacing second molars. In this case, you could possibly consider replacing second molar since the patient has a second molar. But for example, on the upper left hand side, we would not look at replacing the second molar since there is no second molar down here. We're very comfortable and clear that first molar is more than plenty. So now let's go ahead and take a look at it. So as I always do, I went ahead and duplicated the plan. As you can see, this is plan 5. So I'm going to dupe plan 5. So now we have the same plan, and we can take a look at it. So the first thing we're going to look at is we can see that either the dentist submitting the case or a surgical specialist has done a very, very nice bone graft. This looks to have been done, not looks, but it's very likely this has been done with a lateral window, Caldwell Luck approach, to achieve the bone. It looks like we've got a wonderful bone density and fill. We've got a good Schneiderian membrane here intact. This is a very well done graft. And now the patient is ready for restoration. So let's go through it. So in going through our checklist, let's look at our buccal lingual placing. So our buccal lingual placement looks very nice. We have adequate bone around both areas. We are pretty well centered in the tooth, so I'm very happy with this particular situation. Mesiodistal placement will be a little more difficult here because as we're planning a bridge, we don't know if we need to be over here, where we need to be exactly, but what we want to look at is, do we have enough bone on both sides of it? Is there implant or vital structure within this, the safety box? And in this particular case, at this particular time, there is not. The next thing we need to look at is bone level, and this can be a little bit tricky in this case. So what I always like to do is look at right here. This is represents my tissue. Right here represents my bone. So what I would like to do is take a moment to draw that out. This clearly represents our soft tissue, and then this clearly represents our bone. Right there. So we would like, in an ideal world, our implant to be probably somewhere about right here. Now the bigger question is can we put it there without having part of the implant stick out? Or do we need to bury the implant, maybe do a little bit of ostectomy or bone reduction here to be able to have a flat area? And the other thing to consider here is also the amount of tissue space we have here. I personally like to have the implants give us the ability to properly create an emergence profile, which this placement actually gives us a nice ability. Whereas if we had a placement up here, we'd have to bulk it out a little bit. Certainly if we had a placement at this level, we'd have a boom. And that's not necessarily a good issue, and that's a potential plaque trap right in here. So placing the implant is not just about at the level of bone, but it's also about based on the prosthetic outcome. So this is an area that we see quite a few mistakes. So just to kind of give you an idea, most people would try to plant that implant right here because that is bone level. As we can see right here in this particular case, the implant, part of the implant is sticking out of the bone. So that would either require additional grafting, or with this thin tissue right here would likely lead to the implant showing. So the next option is then to drop the implant to about right here. And again, my issue with placing it this close is with this particular brand of implant, we still take a risk of it showing. So I would, as was done here earlier, I would go ahead and drop this implant to about this level. This also gives us some bone around it and also gives us good ability to create a nice emergence profile. So our bone level on this particular implant was nicely done. So our next thing to look at is vital structures, and in this particular case the only vital structure we have is the sinus. So in looking at the sinus, we can see we have plenty of space. In fact, it could be it could be made to be this long. Many of us are comfortable doing that, but honestly there's no real benefit in doing that. So in this particular case, I think a 9mm length implant is fine. I do want to back up to one thing here, and that would be implant sizing. We've sized this for 4 by 9. I think, that might be the right size, to be honest with you. Again, because if we went with a 5mm implant, my issue is not down here. My issue is more right here. Are we going to have bone loss? Are we going to have thin bone that may be resorbed away from the trauma of the surgery? These are all good questions, and again, a lot of this also depends on the implant size, the implant design, all of these things. Just to give you an idea, let's take a look at this particular implant. Instead of doing the Astra in this particular case, let us place a Nobel Active, same 5 by 10 implant. And if you notice, the neck of this implant will slope in, likely giving us more bone here to be able to use a wider diameter implant. So, that's one benefit of this particular implant. If not, we could also look, for example, at the Bicon implant. So let's take a look here at this particular implant, and let's say if we went with the 5 by 8 or 5 by 8 in this particular case. Again, you can see also with this implant we have a slope, in slope here that allows us to preserve more bone in this particular area. Again, there is no right or wrong answer in terms of what implant we use. Every implant has its own benefits and negatives. It's all a matter of what your comfort level is. So I can understand why we would have chosen to go with the 4mm implant here with this particular brand of implant. The next thing that we're going to look at are two things: are occlusal, restoratively based. That would be the occlusal plane and the occlusal table. And these to me are the most important things that we have to look at, because our goal with implants is to create a long axis support. So what I like to do, and to illustrate this a little bit better, what I would like to do is get this a little bit about right here. And what I would like to do is just kind of draw what it is I see. So what I see is an occlusal plane like so. Okay, so in an ideal world, we would want this implant to be going pretty much straight up and down like so, like so. That way we would have more level occlusal plane. But you know, in this particular place, what I'm seeing is this implant, these teeth, as you can see, are crooked, pointed down. So ideally, if we went something like this, now we can see how we're suddenly starting to get our forces more along the long axis of our restoration. So, you know, as we can see here, as we look in this view right here, we can see our forces are more along the long axis of this tooth. And to better illustrate this for you, what I would like to do is just do a drawing here. And what we can see here is our tooth, like so. And we want this implant, this is the long axis of our tooth, and this is probably what our roots would look like there. And we want this implant to be centered and forcing this way to properly support this restoration. So to do that, we need to tilt this one up. Now, the bigger issue comes, let me go back here. Also, let's go ahead and look at our occlusal table. And right here in the axial view, we can see that so far our implant is coming out the central groove. We're a little to the distal in comparison. So again, what I like to do is just draw the outline of my teeth visually, so I can kind of see what it is I'm looking for. So in an ideal world, this implant would be about right there. If we were doing an implant right here, and this implant would be about right there. So now we, you know, have an idea of where we want these implants to be. So again, if we take a look at this one, we're pretty good right here. Now the bigger question comes in is as we're going to this particular tooth. So I'm sorry, let me go back again. This implant is a little distal, so we have two choices. One, we could tilt it to the mesial, okay? Or alternatively, we could translate the entire implant to the mesial, which is probably the more appropriate thing to do in this particular case. So that is more an ideal placement there. So now let's go ahead and move over to tooth number 5 in this particular case. So again, if we take a look at it through our buccolingual positioning, we're pretty good here. We have a 3.5 by 8. Certainly, I think, you know, ideally, I'd like to go to a 9mm implant here. I would like to have something a little bit longer. With the sinus, we can bump right up against that bone. Don't hesitate there. And you know, again, you know, we're going to be a little bit thin right here. And the bigger question is going to be our surgical technique. How is our surgical technique going to affect this bone right here? If we flap, does it affect one way? If we don't flap, does it affect one way? And these are all the questions that we have to ask. How big of a drill are we going to use? Is our implant going to condense on this area? So these are the things that we have to ask ourselves and understand when we make this plan. So we'll say that mesiodistally, buccolingually, this positioning is fine. Mesiodistally here as well, we are more than adequately away from the tooth. No problem there. So we're going to vital structures, no problem there. So let's just go ahead and skip over to our occlusal table. And again, we can see that we're slightly, if we look closely here, we're slightly more to the buccal than to the lingual. So to fix that, we could move it, translate it, and move the entire implant. And you know, it could benefit from a little bit like that, but more of a tilt is necessary. And again, when we tilt this implant, the bigger question is, are we going to get it too thin? And I would personally believe that that is too thin. So this may be a situation where we have to compromise based on the bone volume that we have and the implant that we are using. But again, the bigger thing I want to look at is the occlusal plane on this particular one. And to demonstrate that, let me come like so. So now we can see that we have one implant pointed this way, one implant pointed that way. So the question is, how do you fix this? And do we need to fix it? And in my opinion, we do. This is not a good load for these implants, even though they'll be splinted together. I think that will help. You know, again, to kind of illustrate my point with this, is if we were to design a custom abutment coming out of this, it would have to come out like so, and then it would have to just then bend like that to get a good custom abutment to support the restoration, and we're going to have some offloading there. So the proper fix for this would be to do something like that. Now you can see how nicely this is level. In fact, it may even be parallel with our other implant. But now what do we have to deal with? A vital structure. So this may be a case where we have to purposely place this implant right here and do an anterior cantilever, because we're trying to avoid this. Now oftentimes people will say, well, why is that the case? And you know, again, my drawing skills aren't the best, but if we were to place these teeth back in here, I would bet money that these roots were curved for these teeth, as so. And as we got right here, these roots were curved. And as we got right here, these roots were curved. And that's one of the things that nature has a benefit of. It has the benefit of curving roots and allowing us to load that way. We don't have the benefit of being able to curve our implants. So you know, these are the things that we just have to be aware of. So in a case like this, you know, I would probably have a tendency to want to load this something like so. That way we could you know, have an anterior cantilever. You can see here that we can't get much closer to this adjacent tooth. And this is probably more of an ideal plan right in here. So the last thing I want to do here is I would like to just go ahead and parallel these implants. So we'll go here to change implant, and right here let's parallel that to number 3. And now we have tooth number, the implant, the mesial implant parallel to the posterior implant, and this has some benefits. One is we can consider doing a screw retain bridge in this particular case now, because the hexes will line up as long as we place the implants properly. And we have better loading of the implants. So hopefully this gives you a better idea of how we would like to ideally take care of these implants. So thank you very much, and if you have any questions, please don't hesitate to let me know.